Good morning, all. Welcome to the Carsey Policy Hour, the Carsey School of Public Policy's monthly discussion series for people passionate about the issues and policies that are shaping New Hampshire communities. The topic this month is the Medicaid Unwinding in New Hampshire. My name is Yusi Terrell, and in addition to curating this series, I serve as training director for Carsey's Center for Impact Finance. As folks are entering, please type your name and your organization in the chat so we know who's here today. And as always, your questions and comments are welcome in the chat during the discussion, afterwards, during the presentation. I'll include as many as I can in the discussion, and we'll also follow up with the recording and slides. Thanks as always to our partners at the state's Bureau of Education and Training. The BET's Certified Public Manager Program feeds into the Carsey School's master's programs in public administration, public policy, community development, and global conflict and human security. Our partners are also at the New Hampshire Municipal Association. NHMA works to strengthen New Hampshire cities and towns and promotes effective municipal government through education, training, advocacy, and legal services. Our speakers today are Deborah Fournier, Director of Health, Law, and Policy at UNH's Institute for Health Policy and Practice, and Jay Couture, President and CEO of the Seacoast Mental Health Center. Our topic today is on the unwinding of Medicaid coverage following pandemic-related continuous coverage from 2020 to 2023. The Carsey School has had a long-serving research stream into issues affecting vulnerable children and families, including access to healthcare and health insurance. Back in 2017, Jess Carson, who directs Carsey's Center for Social Policy and Practice, researched the expiration of CHIP, the Children's Health Insurance Program. Folks may remember was a joint federal and state program that extended health insurance coverage to uninsured children and families with incomes too high to qualify for Medicaid, but too low to afford private coverage. Carsey also has research and publications on Medicaid-related work requirements. Both of these, and our discussion today, address the intractable question of how to provide limited government supports where they are most needed, while also helping recipients who no longer need those supports. The Medicaid unwinding process began last year in 2023, but as you'll hear, it's a long process that will have even longer effects on individuals, families, and service providers in New Hampshire and nationally. Deb will kick us off providing history and context. Just as a brief intro, she joined the Institute for Health Policy and Practice as a senior associate for the Health Law and Policy focal area in 2020. Deb is also the former Medicaid Director for New Hampshire and will be supporting IHPP with regulatory and legislative reviews, analyses, and reports on state and federal policy developments relevant to New Hampshire's vibrant health policy landscape. Over to you, Deb.
Thank you. Good morning, everyone. I'm going to, at my own risk, bring up some slides. Please bear with me for a moment if my sharing is not completely smooth, but I think does that look appropriate on your screens?
Looks great.
Okay. So we're going to talk about the Medicaid unwind this morning. And I want to start with the big picture of what Medicaid is, just so that we are all on the same page. So Medicaid is a almost 60-year-old program enacted at the same time as Medicare. That is a publicly funded health insurance program for low-income people in the United States. Every state can choose. It is not a requirement to have a Medicaid program, and currently every state in the union has chosen to have a Medicaid program. And if a state does choose to participate in Medicaid, there are certain baseline groups of people that the Medicaid program must cover. Those are called mandatory populations. And there are certain baseline services that the program must offer to those people whose insurance they provide, and those are called mandatory services. In addition to those mandatory services and those mandatory populations, a state can choose to add additional groups of people called optional populations and additional groups of services called optional services, depending on the policy environment, the goals of the state, its budget. In return for following those federal outlines, the federal government always pays a fixed percentage of the cost of the program, so that no matter what happens, if there's a Great Recession, if there's an AIDS crisis, if there's a COVID outbreak, and the roles of the program swell, there's always a guaranteed percentage of the cost that the federal government pays, and it's never less than 50%. Okay, so those are the basics. We're going to go on to the next slide. So historically, Medicaid eligibility was built around people who were receiving cash assistance from the government, that used to be known more colloquially as welfare. And in general, those groups can be described as low-income people who are kids, low-income people who are senior citizens, low-income people who have disabilities, and low-income people who are pregnant. And so that had been the lion's share of Medicaid eligibility for many, many, many years. And then with the Affordable Care Act, there was the policy change to require states to cover adults who were just low income with no other categorical definition. And as this chart shows, the income levels, the income eligibility, like how low does your income have to be to qualify, is different for every single eligibility category. So the dark gray is the federal poverty level up to which that eligibility group's income can go and still be eligible. I highlighted the yellow, that's low income adults. That group became known as the expansion population, which was the topic of a Supreme Court case and a lot of political activity in New Hampshire and many other states. The majority of states have elected to offer Medicaid expansion coverage in their states, but I think there's still 12 to 15 states that have not. So in some sense, Medicaid is something of a Frankenstein monster that's been built over time, depending on the political will to add groups of people who could be eligible for coverage and to increase income levels of people who could be eligible for income coverage. It was not created, all of these categories and all of these income eligibility guidelines were not created all at the same time. And the variety, the variation of those different categories is evidence of, you can see it was just built as the political will was there to offer coverage for those people. So in New Hampshire, this is what our January 2024 population of Medicaid covered lives looks like. We had 86,000 kids as of that date, 60,000 expansion adults, and then about 24,000 folks that would be considered to be elderly and or people with disabilities. And then another 13,000 people who are low income parents, caretakers, former foster kids, et cetera. And then we have a small number of kids with profound disabilities who receive in-home care. What is notable about this is that kids, pound for pound, are the single largest eligibility group that Medicaid has. And you can see that here, that compared to just the standard adults, the expansion adults, the 59,000 standard adults, we have 86,000 kids. Okay. So what is the unwind? Really short, really quickly, or as briefly as I can. Because of the COVID-19 outbreak, every Medicaid program in the union was offered additional federal match. Remember how we talked about the government always pays a fixed percentage of the cost and it's never less than 50. During the public health emergency, the federal government said, we will add to that. We will give you additional FMAP. I think it was around 6%. And in return, we want you to keep everybody who is on the rolls of Medicaid on the rolls of Medicaid with no eligibility checks and no eligibility discontinuations, except for some very, very, very specific things, like the person moves out of the state, the person calls up and says, I don't need this coverage anymore, the person passes away, and the person, I think, committed fraud. Okay. So typically, so during those 3 years, from March to March, from 2020 to 2023, Medicaid members did not have to renew their eligibility. Typically, Medicaid members have to renew their eligibility, which means submitting information, getting it all verified. They have to do that once every 12 months. For some smaller groups of people, that eligibility check is once every 6 months. Okay, so the rolls of Medicaid enrollment grew precipitously during those 3 years as a result. Now, in late 2022, Congress was still very busy passing COVID relief bills. Congress set a date for ending this continuous enrollment requirement and said that it was April 1st. So as of April 1st of last year, members of Medicaid who had been on Medicaid for those last 3 years, and anyone before then, had to now start again, or for some of them for the very first time, submitting renewal information to establish their eligibility, because the continuous eligibility requirement was no longer in play. And so April 1st was the beginning of time in which beneficiaries could, for the first time in 3 years, lose their Medicaid eligibility because they didn't fill in their renewal application and didn't validate information like their household size, their income, etc. So the Department of Health and Human Services worked exhaustively to prepare everyone, providers and members alike, for this eventuality. It issued a letter campaign while the continuous enrollment period was still going, to encourage people to update their information, so that if and whenever the continuous eligibility requirement ended, the department had the most up-to-date information about people and would be able to make correct choices and decisions about eligibility. It made phone contact, proactive phone contact with members. When the continuous eligibility, sorry, I'm all over the place. I'm going to finish that first thought. When the continuous eligibility requirement actually ended, it shifted to yellow letters to let people know now is the time. You have a really concrete period of time in which to submit your information. The department used text messaging, used email, and proactive phone outreach to communicate with members. It worked with provider groups and gave them lists of members whose eligibility had been protected during this time, to say these are the folks whose eligibility we can't confirm right now, who we don't have updated information for, and who should submit paperwork with us in order to protect their eligibility if they are in fact still eligible. And there were more than 200 listening sessions and community stakeholder outreach sessions to remind everyone, members and providers alike, of the situation. And there were several false starts at the federal level in those 3 years of when we thought the public health emergency was going to end. And so there were several times when it felt very urgent to do stakeholder engagement and remind people that they needed to stay abreast of their paperwork. So there was a very serious campaign, and it was almost as long as the public health emergency. The department started working on that in earnest in 2021. The department also extended the period of time in which, got federal authority to do this, extended the period of time in which a member could respond to requests for more information, and expanded its capacity to verify information electronically, so that when it was possible, the member didn't have to necessarily contribute. It just had to verify, yes, that's my information. And then the state could validate the rest. That's called, to some extent, ex parte eligibility. So what actually happened after all of this prep and all of this outreach and all of this work. This is what happened. The rolls fell by, well, the rolls had grown by about 30% as of March of 2020. And at the high water mark, the enrollment in New Hampshire Medicaid in March of 23 was around 251,000 people. And now you can see that total there on the far right-hand side for total enrollment is 182,000 people. So that's essentially a 30% change in the enrollment numbers. And as you can see here, that all of the horizontal rows are different eligibility groups of New Hampshire Medicaid members. And you can see the chart, how there's a steady increase in all of the groups except for children with disabilities. And then there's a steady decrease. And that's the trend of continuous enrollment until March of 2023, and then the end of continuous enrollment. To put it all together in one trend line, this is what that looks like. There were parameters around which, the state had to perform the functions of reinitiating eligibility checks. And the baseline is it could never start a renewal, which is the process by which someone would be determined eligible again. They could not start a renewal for more than 1/9 of its Medicaid population in any given month. So it was not permissible for any state to simply say, okay, everybody with questionable eligibility as of April 1st, you're all done. They had to do it in a sort of distributed way, month by month, and they had 12 to 14 months to do that. So because New Hampshire started in April of last year, we are just nearing the 14-month mark now with respect to finalizing and finishing everyone's renewal who had protected eligibility during that time frame. Okay, so that's my level setting and context. I don't know if there's questions and I haven't looked at them, but Yusi, should I just stop sharing and have Jay go, or should we engage a little bit?
Yeah, let's have Jay go.
Okay.
We'll have it as a package.
All right, thanks so much.
All right. Going to share screen. Switch this. Presentation. There we go. Thank you. Good morning. Thank you for inviting me to be here today. So I was going to start with just giving you a little bit of a sense of the mental health centers in the state. Our center, Seacoast Mental Health, is one of 10 in the state. We each have regions that are assigned to us where we are responsible for providing services for individuals who are living with mental health and substance use disorders. We are governed by RSA 135C, and one of the tenets of that legislation and the rules that promulgate that law are that we are required to provide services to individuals without regard to ability to pay. And that really comes into play as we talk about what has happened with the Medicaid unwind. So some quick facts. 1 in 5 adults will experience mental illness in any given year, and about 1 in 20 experience serious mental illness each year. 1 in 6 U.S. youth experience a mental health disorder each year, and 70% of youth in our local juvenile justice systems have a mental illness. Suicide is the 12th leading cause of death overall in the United States, and it's the 2nd leading cause of death among youth aged 10 to 14. Medicaid is the largest payer for community mental health centers. And I think this sometimes comes as a surprise, particularly to other sectors of healthcare, because it's a much smaller percentage, for example, in the hospital payment system or primary care payment system. For the mental health centers, it can be as high as 90% of their revenue. It ranges 60 to 90%. And overall, the mental health system sees more than 50,000 people each year. I think last year it was actually about 57,000. And those individuals cover a diverse spectrum of need. So we have people who are in long-term care who are severely and persistently mentally ill or severely mentally ill. We have low utilizers, or people who need a little bit less frequent and intense services. We provide services to children who are severely and emotionally disturbed, including those who are involved with other agencies that we partner with, so DCYF and juvenile justice. We provide services, both treatment and preventative, to older adults. The community mental health centers partner to provide a service, a prevention service for older adults that's known as REAP, Referral, Education, Assistance, and Prevention. And we provide services to families, to public and private partners. We may provide mental health first aid trainings within schools, within businesses, local businesses. We provide trainings and coordination of care with partners throughout the state and in many different sectors. As the Medicaid unwind process progressed, like Deb described, the state did do a really intense and thorough job of outreaching individuals, trying to outreach individuals. Some of them it was hard to connect with or locate, and help people to understand that they needed to take some active steps in order to maintain their Medicaid coverage. In some cases, they weren't eligible any longer because they no longer met the income requirements. In some cases, they couldn't find documentation. And in some cases, documentation was submitted but somewhere lost along the way, and it had to be resubmitted, sometimes multiple times. So there were a number of different challenges that led to people who should have stayed covered, losing coverage for a partial or permanent amount of time. But the challenge that we had as community mental health centers is these individuals were already engaged in care. So ethically, you can't just say, oh, I'm sorry, you got your letter and you're no longer eligible. Your case is going to be closed. It's not quite that simple to be able to do that. And while some people were able to access other insurance coverage, so we did try to connect people who were over income to the marketplace, or some got employer-based coverage, commercial insurance doesn't cover the services that we provide that are community-based. So targeted case management services, a service called functional support services. These are services that we are able to provide that help people to connect with resources that they need, and also to manage their symptoms so that they can stay in their community of choice. And for the individuals who lost that coverage, they were offered sliding fees, but sometimes people aren't able even to manage the sliding fee, or don't choose to spend what limited resources they have for a service that we might think that they need, and may have chosen not to continue coverage. At the same time that this was happening, Medicaid spend downs were reinstated. Medicaid spend downs are essentially a monthly or 6-month deductible. For most people, it is monthly. If you are over the income limit, that amount that you're over the limit becomes your spend down each month, and you need to accrue that amount in medical services in order for your Medicaid to be turned on. Community mental health centers and hospitals are virtually the only providers who provide care during that time when someone is considered out. It's an in and out program. And they use the services that they receive from the mental health centers or from a hospital stay so that they can be in for the month or for the 6-month period. And then that allows them to get their medications covered, to get other medical services covered. As a result of these changes, the people who lost coverage, the people whose coverage transitioned to commercial insurance, or the people whose spend downs were reinstated, the mental health center saw Medicaid revenue decrease and uncompensated care increase. At my center, by the month of January 2024, we had 898 patients who had lost their Medicaid service or Medicaid coverage. That was about a third of the people that we were currently seeing who were covered by Medicaid. Our Medicaid revenues were down 1.1 million. They're slightly down higher than that at this point. And we had to take action to deal with that as an organization. So we had some positions that we froze, positions that had been anticipated in our budget for this year that we didn't fill. We changed a planned COLA increase. We reduced it from what had been budgeted to what we actually provided in January. And all of this is happening at a time where, as an employer, we are still facing workforce challenges like most employers are. We're running 21 to 25 vacancies at any given time, and there's an increased demand for care. And you're seeing this replicated in all of the mental health centers across the state. Patricia Carty, who's the president and CEO of the Mental Health Center of Greater Manchester, presented to the Medical Care Advisory Committee, sharing similar information, but their center is much larger than ours. And at the time that she presented, their Medicaid revenues at that point were down over $2 million. So this is happening statewide, and we are all trying to figure out, how do you still provide the care that people need that will help them to achieve their recovery goals in the community whenever possible, and still meet the financial requirements of running your organization. And it's been challenging. It's been very challenging. Staff have continued to work with individuals to try to make sure that they have access to the benefits they need and to the services they need. And on the larger, higher level, we've been advocating for assistance to help mitigate the impact. We understand that, and the word I've heard used sometimes, the system is trying to right size. What is the right number of people who should be eligible for Medicaid? So the experience that we're having isn't to say that the state did anything that they shouldn't have done. It's really to say the unintended consequence of that was that we have seen a skyrocketing of uncompensated care that the centers can't absorb and still continue operations without having to make significant changes or sacrifices. So we're working at the state level in concert with all of the centers together, looking to see if there's a way to mitigate that, and how can we find other revenues or other savings. So some is offset a little bit by the commercial insurance that does cover things like therapy and psychiatric visits. Grants and applications for grants are certainly increasing, I think, for all of us. But I think that we need to make sure that all of the powers that be understand that we are going to need a commitment to adequate and sustained funding for all of the mandated service requirements within the system. We know the work is important. Community mental health centers provide a really important service on behalf of the state and on behalf of the residents of the state. So we need to make sure that we work together to find solutions that allow us to continue to provide care. So thank you for inviting me here, and I'm certainly open to any questions.
Wow, that is fantastic. Thank you so much, both Deb and Jay. Please feel free to put questions into the discussion. I'll bring some of those up, and we'll start with a question from Susie. Prior to 2020, how many people on average lost coverage annually because they did not submit the eligibility paperwork for verification?
So that's a great question, and I don't have specific numbers. What I can tell you is that phenomenon is called churn, right? So there are typically, like I said, folks reapply essentially every 12 months for their coverage. And if they fail to do so, then their coverage would end. Now, folks at these income levels, I want to point out, their income is checked in the month in which they apply. So if they have a seasonal job where, like landscaping, where in the summer they are busy, They may be above income for Medicaid in any of those months that they are outside working. But then the winter comes, and like this winter, there wasn't a lot of snow. So their income plummets and they become eligible in that month. It's very common for people to have significant income fluctuations for folks living at this income level. And people can and do lose coverage and then reapply and come back on the program. I think one of the things that I want to point out is that to go from 180,000 people to 250,000 people means that there is a static group of people, sort of to Jay's point, who remain in need of services and who at some given point are eligible for Medicaid. But because of the conditions of their world, of their environment, keep and lose Medicaid coverage throughout the year. I will absolutely check with the department about what the average monthly eligibility churn was prior to 2020. But it's not a new phenomenon. I think what the continuous enrollment showed us is that there is a large group of people who are vulnerable and technically at some point in the year are eligible for Medicaid services. And that churn also, I think, goes to some of Jay's point about the people are there, whether or not the people are there in those general income ranges and in need, regardless of whether or not they are enrolled in a program. Most of us who have employer-sponsored insurance don't have to worry about re-enrolling every year, right? We sign up once when we take a position. We may have an open enrollment every year where if you have options for your health insurance, you can add people to your health insurance, or you can, if your employer has access to a variety of carriers, can switch carriers. But most of us do it once and leave it, right? And folks in this situation have the added challenge of having to do it annually, and folks at these income levels are playing whack-a-mole with fires, metaphorical fires, every day. And so they're putting out the fire that is most pressing around their environment. And they are thinking things like, a mountain of paperwork came for me in the mail, but I have to make sure that my kid gets to this field trip tomorrow, and I only have $8. And I don't know how we're going to take the bus to get to the field trip. And so I got to call all my people today to find out who can help me with that, to get her to the place where she's supposed to be dropped off. And my kid isn't sick today, and I'm not sick today. So I'm not worrying about eligibility paperwork today. I'll worry about it later when I have to, when it's critical for my people. So that's not really the question Susie asked, but it's an answer to a question Susie didn't really ask. But it's a point that I want to make, which is churn definitely existed prior to the continuous enrollment requirement. And yes, there is a correct amount of money or a correct amount of people that I think sometimes is in the State House's mind about who should be eligible or on the Medicaid rolls. But again, I would posit that there's a large group of people who at any given time in a given year are eligible for Medicaid. And there's a real question, I think, now about should funding for our healthcare systems be separated from those disruptions in coverage, because the people are still there and the need is still there, but whether or not they have filled out the appropriate paperwork really disrupts the healthcare delivery system.
Right. There's not only the irregular income, the seasonal income that disrupts eligibility as the policy is written, but also just the disproportionate effort that poor people are expected to bear I remember reading about financial diaries in the US and abroad, and how actually people living in poverty had more sophisticated money management skills in some cases than those of us who, who are able to have some float up and down. And I'm imagining families that are choosing their medical procedures or their medical supports, knowing which months they'll have coverage or won't have coverage. It's just an extra burden. I have to ask, the children with disabilities on your graph, Deb, why was there the steady decrease of that group?
I don't know. And it could be that they aged out of, so that eligibility category, right, is for kids 0 to 18, right? And then they become eligible for coverage under the adults with disabilities waiver. So it could be a reflection of the fact that our number of young people is not growing. It's in fact shrinking, and that people are aging out of that particular eligibility category and aging into the other pie chart that is the adults with disabilities.
Right.
I don't think there was anything that, well, and yeah, that's all I'll say.
Interesting to get into, but certainly the overall trend is clear.
Yeah.
We have folks on the call who are definitely interested in a national perspective. And so I'll put out 2 questions and would love to hear Deb generally and then Jay and mental health in particular. So John asked, what, if any, have been the differences in how states responded to the federal change and the differences in results between them? And Yulia asked, how much money and grief could be saved if national health care is instituted?
Oh boy. So state experiences, to my understanding, or state responses have been varied. Some states staggered their renewals of eligibility by how long people had been in the program. So last in, first out. Is that right? Last in, yeah. Last in, first out. Or first in, first out. And other states like New Hampshire tried to think about who was most likely to no longer be eligible and start with those people. And it protected, to a certain extent, for most of or for the first 6 months of the unwind, it protected people with disabilities and kids from being renewed until relatively late in the process, to give those folks whose needs are probably not changing and whose circumstances are not dramatically changing, give them lots of time to catch up. I don't live in those other states, and I've never been a Medicaid director of those other states, so I can't speak in terms of the detail of how they've managed. So I'm gonna, and as for a national health insurance program, I too have that question. Can I say that?
Sure.
So, Jay,
There must have been, budget estimates. I know we have 2 people from the New Hampshire Fiscal Policy Institute here, and I'm sure there are, these national projections. And so I'll try to track that down, or maybe the 2 of you can help me and we'll put it in the follow-up. Jay, what about in mental health in particular, comparing between states?
So I think just in what I read in the media, it has been very different state to state. And there have been some areas of the country where it's been reported that lots of individuals sort of wholesale were just dumped from the rolls. So I do think that New Hampshire was very thoughtful, and I appreciate that, but that doesn't change the outcome. In needing to still address the issue of needs for people who no longer have Medicaid coverage, but still have care needs, particularly for those individuals who are already participating in care.
Yeah.
In terms of national coverage, I think for me, it really would take some thought into what that plan looks like. So for example, I noted at the beginning of my presentation, Medicaid is the best payer for the community mental health centers. And that's because Medicaid is a program that is designed to serve those populations who have disabilities and high needs. And that's who we predominantly provide care to. So there's a good match there. Many of our patients have dual coverage on the adult side. So they have Medicare and Medicaid. Medicare is much more restrictive in who can provide care that's covered and in what they cover. So when I hear Medicare for all, what I sometimes think is if they don't expand the covered services, then people would no longer have access to the community-based care, to the care that's provided by bachelor level staff, which can be key to giving support to people in the community. And so I would want it to be a thoughtful process where we were really looking at, you know, what is it that the plan needs to contain and how do you do that? And then what would the costs be related to that?
So to Jay's point, and she mentioned this in her remarks, Medicaid pays for services called targeted case management and functional support services that are wraparound services. So they're not hard medical services, but they are vital services to effectively care for folks that come into a center like Jay's. Commercial health plans, the qualified health plans on the marketplace and other commercial health plans that are available to people through their employers typically do not pay for those. The other thing that commercial carriers do not pay for is long-term care. So home and community-based care, skilled nursing, I mean, Medicare pays, I think, 3 months of skilled nursing facility care. But for the vast majority of people who have public payers for their long-term care, it is Medicaid across the country that pays for that. And I shared Jay's, it's a very weedy response. Like, could a national health insurance be administered at the federal level? The way Medicare is, because in Medicare, right, they send you a card 3 months before you're eligible, and then they tell you you're about to be eligible, and then they tell you you have to tell us you don't want to be in the program, right? And they just assume. If that system could be applied, that would be great. But to Jay's point, are we going to offer Medicaid benefits to everybody so that everybody gets, if they need it, access to targeted case management and functional support services? I can tell you that politically and financially, that would be a very complex argument, and not a popular one. So I don't disagree about the eligibility and enrollment, and especially the community mental health centers are paid based on enrollment, right? And so if folks lose their eligibility, the centers took a huge hit because that was the baseline for their financing. And I think we should explore, or I think it's time to explore other ways of financing healthcare delivery that isn't just about the volume of people and the volume of services, but rather thinks about the need for a public good, like community mental health centers that can provide behavioral, and they are struggling to find people to be providers. Like, the workforce shortage is real. So it's not that there is no need and that it's an unused or underused system now.
There's a question in the Q&A. Can you elaborate, Jay, can you elaborate on the comment about commercial insurance? I think not covering the services that are needed. I think you answered that, but whoever typed that, if you could type again if you'd like further clarification. I think the case manager is just such a clear one example. I'm sure there are others as well. And your point about, national healthcare system, I hadn't considered this, this constant question between the equity versus equality, right? Is everyone getting the same services, or do those who need a little bit more? People who were on the Carsey Policy Hour 2 months ago, when we were talking about solar and the benefits of renewable energy, especially connected to lower income individuals. It's something similar where there's all these federal incentives for putting solar on your roof or replacing air conditioning with a heat pump or those sorts of things, but you still need more of a curator through that process, a guide through the process to overcome some of the questions about just complications in daily living and deep-seated mistrust in, you know, in the government, whether it's financial or otherwise. So I know I'm going to take that away and think about that one.
I could add a little bit more to the commercial coverage piece, and
Great.
we have been working with the Department of Insurance to explore how can we make it a reality that commercial insurances also would cover these services. But one factor that is a barrier to that is ERISA. That commercial insurances that are covered by ERISA, which means they're self-funded plans, which I think are the majority of plans in New Hampshire, don't have to abide by New Hampshire insurance rules. So New Hampshire's had a statute on the books. It's my favorite one, RSA 41518, that requires commercial carriers to cover our services, regardless of which of our staff provide them. They all have to be qualified by rule. So we're not just putting random unqualified people in positions, but they need to cover those services. And for years, that was a really effective tool in getting commercial carriers, not necessarily to cover the community-based care, but to cover, we hire a lot of staff right out of school and provide them with supervision until as they work towards licensure. And those staff could provide care and we could be reimbursed for it for therapy services and other office-based services. And so if we can not require those carriers to cover whatever the state wants them to cover, then having that statute on the books is less effective because those plans are excluded. So there's a lot of opportunity, I think, for ongoing discussion and searching for solutions.
And the ERISA plans of the commercially insured, they do make up in New Hampshire. They do make up about half of the commercially insured lives. So it's not.
Those would be Blue Cross Blue Shield, or
it depends,
are,
right? It could be any carrier. It could be Cigna, it could be Anthem, it could be Harvard Pilgrim. It depends on the insurer, which in these instances is usually the employer. Does the employer purchase wholesale its own health plan from a health insurance carrier, which is self-funded, or is it fully funded, which means it purchases a standard benefit package that carrier offers. So you can't distinguish by, is it Anthem or is it Harvard Pilgrim? You have to distinguish by how the employer has actually arranged the financing.
Mm-hmm.
Yeah.
Interesting. So Jay, I would like to return to your talk about right sizing the field and the responses that mental health centers, community mental health centers are taking. And some of them are the typical responses faced by most organizations, for-profit, nonprofit, who are facing economic challenges. So not filling budgeted positions, not replacing departures, reducing cost of living increases, considering mergers or consolidations. And then others of the responses, the specific positions or other responses that the mental health centers are taking are actually, we talked about this, eating the seed corn for the ability of the Medicaid system or generally healthcare for low-income individuals and families to be able to continue progressing. And so could you talk a little bit more about those that are, that are connected to the system's growth and what long-term effects any cutbacks now are having on those opportunities?
Right. And I think at this point, so we've made, when opportunities have arisen, some changes, as I noted when we discussed this pre-show, positions that where people left and we didn't fill them. But you do have to be careful in looking at particularly the clinical positions and making sure that if you have an opportunity to bring someone on, that you're still doing that, because otherwise you not only reduce the access to care, but you reduce the access to a revenue stream, since we're paid for, even though we are currently in the Medicaid system, it's a case rate. You still need to have the ability to bring people into the system to provide care to that population, because you don't just get a check and get to keep it, even if you don't care for the population. I want to make sure people understand that there's an expectation and a maintenance of effort threshold requirement currently, that you're providing a level of care that is adequate compared to the services that you're being paid for in the cap rate. And if you're not able to sustain that and you keep reducing, or if you eliminate an entire program, and I'm not saying that anybody has done that, but we all look at these things all the time, and you think about what are the needs in the community and what are sort of the areas where we're seeing those needs increase, and how will my decision today impact our ability to do that tomorrow? So if you're just reducing, it's like you get into this vortex of death spiraling down. And instead of, sometimes these are the times we need to find ways to continue to grow in hopes that you can continue to get people in and provide care, but trying to do that and still have a bottom line that doesn't cause great concern for your board members, for your banker, for the state. We all have a requirement to report our fiscal metrics to a whole host of external sources, including the state. And we have benchmarks that we're required to meet in terms of, just like any business, cash on hand and different financial ratios. And if we can't find a way to have resources that are adequate enough to allow us to meet those metrics while also meeting need. And I do think that the centers have great angst. We know that it's hard for people to access care. We just take out the Medicaid unwind just because of the workforce shortages. We all are struggling, like every employer. And with integrated behavioral health, which is great, it has just expanded who we're competing with for hiring. And so if we can't pay market-based rate wages to our staff, they're going to go work somewhere else.
Jay, I realized I didn't give you the intro that I gave to Deb, and note your more than 30 years of progressive experience, your leadership on the New Hampshire Community Behavioral Health Association as president, and vice chair of the Foundation for Healthy Communities, and especially your integral part of the team that curated New Hampshire's first 10-year mental health plan in 2008. And I know that, this is the mental health plan is updated every so often. And I guess I wanted to prompt you again we had talked about the data requirements in particular for improving, I guess, the additional requirements on integrated behavioral health and some of the tracking and accountability that we anticipate in the coming years.
Yes. So currently with the association, I just want to clarify, I was president. I'm currently the secretary of our New Hampshire Community Behavioral Health Association. Yeah, so one of the positions that we didn't fill that was in the budget was a data analyst. And as the state considers moving towards certified community behavioral health centers, which really are a much more integrated, holistic model that we all in the mental community agree clinically makes a lot of sense, it requires both an infusion of funds for the non-Medicaid covered population, but also a lot of data information to really understand who we're serving, how we're serving them, and how effective that is. And that's a level of sophistication that we would all need to grow. There are currently 3 centers in the state that have SAMHSA grants that have been working on this as trying to understand the costing and what kind of data is required. And I think they could speak to the detail of that at great length. But I know it's been a heavy lift for them. I know it would be a heavy lift for us. I know it would be a heavy lift for the state. The state has had various data reporting systems. And like you mentioned, I've been in the system for over 30 years, so a really long time. And whether it's for the good or the bad, sometimes I have a lot of institutional memory of things we've done in the past and whether they have been successful or less successful. So we've had data reporting called MISIP was one of the first ones. We're now at Phoenix 2, I think. And I'm not sure that we're all, state or private, at the level we're going to need to be really successful in producing and understanding the kind of data. It's a work in progress to get to the point where the CCBHC level of data would be effective. But paired with that will have to be the funding that will be needed to sustain the system.
Thank you for talking about the CCBHC, the status. Richard Snipes from Greater Nashua Mental Health noted that they too have been seeking that status to help with reimbursement rates and other funding. And Rob, if you are able to talk in the chat about data and data management, what is needed beyond what a typical community mental health center might be tracking already, I think that would be interesting for the group. We have time just for one or two more questions, and I'm going to draw from some of the participants here. So we have Matt Kalahane, if I'm saying it correctly, who works at the intersection of environmental conditions and community health. And I'm curious from that lens, if you're looking at climate justice, at climate-related social determinants of health, what communication and or strategic alignment between those in the Medicaid system and those pushing for climate justice and the intersection between climate and health? Is there a discussion at the policy and decision-making level?
So I have just started, I would say, in the last year to see climate and health be connected as policy discussions. But there's a few different ways of thinking about it. One is the very, I would say now, accepted rubric of that where you live, work, play, worship has far more to do with your health outcomes than the clinical care that you receive in a provider office or a provider system. And I don't know how we begin to think about climate in particular as a condition of environment and how that drives outcomes. And then there is the more short-term sense of what policies are going to need to be in place that are different than what we have now to mitigate the climate change that we are experiencing. Like, what else is going to need to be provided? Like, for example, I read recently that a Medicaid program, I think it's in Oregon, is paying for air conditioners. Once we get to that level of benefit, we're getting closer to the types of benefits that Jay was referencing earlier, targeted case management and functional support services, where we are really starting to step into trying to adjust benefits for the actual conditions in which people live, which also is going to be an unpopular and difficult political conversation. But other than I have that, I'm out over my skis on that topic. That's as much as I know. Jay, I don't know if you guys have started having those conversations.
Just starting like you to see this pop up in literature, and probably a lot of opportunity for additional learning for me.
Yeah. So in short, policymakers are aware that it's out there, and it, like a lot of environmental justice questions, feels so big that they're not sure where to start and how to specifically start within the Medicaid system.
Right. Recognizing that there are disproportionate impacts on communities that already have been disproportionately affected. Right.
Right.
Mm-hmm.
Right.
Well, thank you both so much. This has been incredibly informative and lively and so close to home. Really appreciate both of your time.
Thank you so much.
Thanks for having us.
For the those are the Carsey Policy Hour fan club. Our next series is on June 12th. We have Jean Martin, who is director of the New Hampshire Fiscal Policy Institute. So props to the two folks who are on our call today from there. The title is How Economically Secure Are New Hampshire Residents? And noting the disparity, we regularly hear how New Hampshire is one of the wealthiest states in America, but nearly 1 in 3 Granite Staters actually find it challenging to afford the combined cost of childcare, housing, transportation, other basic necessities. So we're going to talk a little bit about this superlative of being one of the wealthiest states serves to mask the financial vulnerability that many New Hampshire residents face and some of the ways that we can approach that. So I hope you'll join us again on June 12th. Thank you so much, everyone. Have a good day.